We'll start off with early stage disease, touching on the adjuvant space, and then switching gears to metastatic space, as we've seen a few updates and approvals here. Katy, can you touch on your treatment paradigm here in early disease, as we now have pembrolizumab available based off Keynote 564 study after surgery?
Yeah, over the last year, we've seen the initial reporting for Pembro in the adjuvant space for a DFS benefit, and then it also came out and reported an OS benefit, which really solidified the benefit for our patients. In the adjuvant space, we know we have the most data, actually the only data for patients who have clear cells. The trial included patients who had T2 disease if they had grade 3 or 4. But what we basically see is that the more aggressive disease, the more likely the patient was, to benefit. Based on that, I will often use a kind of risk of recurrence, talk to them about the potential side effects, which unfortunately can be lifelong from pembrolizumab, and try to have that personalized decision with the patient sitting in front of me. Most of the time, I'm offering this to patients who have stage 3 disease, higher risk, maybe IVC thrombus. For sure, conversations with patients who have lymph node involvement or that are M1 NED. We know from the metastatic setting, patients in RCC who have so much weight features tend to have more of an enrichment. And so if I see that on the path, then that also kind of gives me the inclination to offer.
Katy, any role of PD-L1 testing in this setting?
We just haven't gotten that to work in RCC. There's maybe a hint that it helps to enrich. We still have so many patients who ultimately will have a response and be PD-L1 negative. So currently, if you think kidney cancer, you do not have to think about PD-L1 testing.
And I think we've harped this on based on multiple studies that PD-L1 again is not the best marker, but we'll see how future studies play out. I want to reiterate some of the things that you mentioned, Katy, with regards to the Keynote 564, based off which pembrolizumab in adjuvant setting was approved, was T2 with high-grade or sarcomatoid features, T3, T4, or node-positive disease. As a result, this is now the standard of care for this intermediate or high-risk patient population. Katy, before we move on into the metastatic space, in terms of surveillance scans, what is your go-to modality, and when do you rely on bone imaging, if at all, in early stage?
When I'm doing surveillance scans, I closely align with the NCCN guidelines. Often the type of scan I'll use is dependent upon, because some of these patients may have CKD, either post-nephrectomy or due to other comorbidities. If I'm not able to get good imaging modality because of kidney function with a CT with contrast, then I'll often go to an MRI. As far as the bone scans, per NCCN guidelines, it's not a recommended unless the patient is symptomatic. When a patient comes in with any sort of symptomatic complaint, get that